Brooklyn Independent Television.
Coming up on Healthbeat Brooklyn.
Most patients, they think that hospital is a place where you come to rest.
But how can you sleep when there's so much noise? One hospital is trying to keep things quiet so patients can heal faster.
Are you ready? Okay.
Rehab for a man with COPD, chronic obstructive pulmonary disease.
Let me also check your oxygen.
Almost everyone with COPD got it because of the same bad habit.
I was one of these smokers that it was my right to smoke anywhere, anytime. Now it's don't even smoke near me.
And at club workout, the music and the dancing make it a party. But the promise is better health.
They will get toned. It can help them with longevity, adding years to your life.
All this and more on Healthbeat Brooklyn.
Welcome to Healthbeat Brooklyn on Brooklyn Independent Television. I'm Dr. Monica Sweeney. It's common medical wisdom that you need to feel rested to feel healthy. 8 hours of sleep is the traditional prescription. You also need to feel rested to get healthy, when you're in a hospital, that is. But as Healthbeat's Tati Amara discovered, at SUNY Downstate's Long Island College Hospital, it can get very noisy. And patients often find themselves trying to fall asleep in an audio minefield.
It's no question that we live in a noisy city. But noise in a hospital?
The noise can be a major obstacle for patients who are trying to heal and get better.
Imagine trying to recover with all this racket going on around you. In fact, we could hardly get through our interview without an interruption.
We also have
Nurse Kwashi explained that while obtaining diagnosis and caring for patients, noise is inevitable.
The lighting 16. We do have staff interaction, and that could be pretty hectic and very disturbing for our patients. Most patients, they think that hospital is a place where you come to rest, but it's totally the opposite.
But for the past 3 years, the hospital has been working on the problem.
So what we've done here at the hospital is trying to implement our Healing is in Progress program, which we want to bring awareness to the patients that we are trying to work on reducing the noise level at night. We also want to keep a constant reminder to our staff that they need to monitor their tones, their volume, as they come onto the units. So it's an awareness, it's an ongoing process. Sometimes we do better some months than others, but it's always we're always monitoring this. So
there's some noise.
There's noise, right? That's just an ice machine, all right? And it's the daytime. So again, these are some of the things that we try to mitigate at the nighttime. We try and make sure that the patients don't hear this ice machine going off at 12 midnight.
Your attention, red alert, first floor.
Noise reduction in hospitals is a nationwide effort.
And as you see around the country, every single hospital is trying to limit those. And we learn from each other. What works for some institution, we try here. And again, the publications out there are enormous about how patients are responding to the noise level.
And at Long Island College Hospital, overnight measures include no overhead paging and limited phone use. But how does the noise actually impact patients?
Not getting enough sleep leaves me, definitely at a lessened capacity the next day. So I would imagine for patients that's difficult.
Absolutely difficult. If you have a patient who may be scheduled to go for 2 and 3 hours of aggressive rehab to get independent so that they can go home, a lot of times not having enough sleep impacts on their ability to do so in the morning. And you'll hear most patients say, if I only had 4 or 5 hours of straight sleep, I would feel much better.
And according to a study from Texas A&M University, they would feel better. The study found that patients who slept better had lower blood pressure and fewer instances of rehospitalization. But they're also helping patients get more out of daytime hours by creating a more predictable environment.
So constant communication about what the expectations are limits their anxiety level. And again, they can't, the less anxious you are, the more relaxed you are. Hopefully you can get some cat naps during the day.
So remember, you're going to do rehab today because you have to move. I know it's hard.
Nurse Barrow explained how it's helped her patients.
Moving your limbs even while you are laying in the bed.
I understand.
Once you understand why you are going to be here and why your treatment has to continue, it makes it better because you know what's going on. It's not the unknown, and we all fear the unknown. You have any other concerns?
No, just thank God I'm living.
Okay, I'm glad for that.
In addition to these measures being beneficial to patients, they also play a role in the hospital's bottom line.
The patient satisfaction is key now, right? That has a lot to do
Absolutely.
with how
Patient
you guys...
satisfaction is so key to hospital reimbursement now. Right. Hospitals are being reimbursed on their quality indicators of providing patient care, but also patient satisfaction indicators. If we've seen a decrease in patient satisfaction scores in one indicator, then we know we have to work harder on that.
But she stressed they have a long road ahead of them and very big goals.
Absolutely. We'd like to be the destination hospital for all the patients in Brooklyn. And again, we'd like to be in the top 10%.
I feel like it's a work in progress, too.
It's always a work in progress.
For Healthbeat Brooklyn, I'm Tati Amara.
For a woman, it's one of the most troubling diagnoses she can get, breast cancer. Though our knowledge of the disease is far more sophisticated than ever before, breast cancer still brings with it fears of death and disfigurement. Every year, well over 200,000 American women get that diagnosis. October is National Breast Cancer Awareness Month. It also marks the first anniversary of Maimonides Hospital's new breast cancer center. And here to tell us about it and to talk about where we are in terms of treatment is the center's director, Dr. Donna-Marie Manasseh. Thank you very much for being here this morning. So who gets breast cancer?
Well, thank you for having me. Breast cancer actually happens to any woman. In our breast center, we see women from all over the world. It's one of the reasons I came to the Maimonides Breast Center. We see women of Jewish descent, we see women of Arab descent, we see Caucasians, African Americans, Caribbeans. Many women get breast cancer.
And do men get breast cancer?
Actually, they do. Men are susceptible to breast cancer, not as frequently as women, which is why men don't necessarily need a mammogram, but men do get breast cancer. And I often encourage men, if they happen to feel something on their exam, when they're taking a shower, they probably should come in as soon as possible to have it evaluated because they are susceptible to breast cancer.
I had not planned to ask you this question, but you said when they do their exam, because there's been controversy lately about whether or not women should actually do breast exam. So would you talk about that as a part of screening, and then we'll get to the other screening?
Sure. The controversy around breast self-exams is whether or not it's worth, quote unquote, doing a breast self-exam. Does it actually help you find breast cancers easily? And my thought has always been, I tell my women the same thing, it doesn't hurt to do it. It's an easy enough exam. It's free. You just use your hand. And you can find something that you won't be able to detect necessarily on mammogram because you had your mammogram 6 months ago. Breast cancer doesn't wait for your mammogram to show up. It can show up in between mammograms sometimes. And because of that, doing a self-exam may help find that.
I'm glad you said it doesn't cost anything and it doesn't hurt to do it. What I used to teach my patients is actually to teach your partner to do it. And I thought that they really liked that. And so you can do it yourself, or you can teach your partner how to do it, right?
I absolutely say the same thing, actually. Because I think it's something where it's an important thing to do. It doesn't hurt. And having somebody else do it if you're not comfortable, that's another concern some people have, that it causes a lot of anxiety. They don't know what they're feeling. But somebody else who maybe is familiar with the area might also know what they're feeling, feel something different. And I've actually had some patients whose partners have picked their lump up.
So we don't want women to miss that opportunity.
No, we don't.
To have someone else examine the breasts when they do it with sensitivity. Now, tell me about screening. There's been so much controversy about when to get screened.
Screening, one of my favorite topics. The controversy around screening is when is actually the right age to have someone screened. And presently the recommendation is to get screening at age 40 if you're of average risk. No family history, haven't had an abnormal biopsy. Average woman walking in should get screened once a year at age 40. The controversy was whether that was the right age. Should we wait till we're in our 50s? And a little bit
wait a second. Is it start when you're 40 and do it every year, or start when you're 40 and do it every other year until 50?
So the controversy is around that as well. We recommend, as does the American Cancer Society and other societies that treat breast cancer, to start when you're 40 and do it every single year. So an annual exam with a mammogram every year starting at age 40. The controversy is whether we need to do that. Should we do it starting at age 50 and doing it every other year, or should we even do it starting at age 40 at all for the average risk woman?
So when you get a mammogram, that by itself is not anything except uncomfortable. Are there any new screening techniques that are available now, commonly available, not research available, commonly available screening techniques?
Well, there are a number of actual other imaging modalities that we use for the breast. And as I mentioned, for the average risk woman, we usually will use a mammogram. But if you're at an increased risk, we often will add other imaging tools like an ultrasound, a breast ultrasound. People who have had children are familiar with what ultrasounds feel like, or an MRI. And I think that's where the importance of understanding what your risk is can help evaluate whether you just need a mammogram or do you need a mammogram, ultrasound, and MRI as part of your screening.
And when you do a mammogram, do you do a mammogram and an MRI, a mammogram and a sonogram at the same time so that you see the breast at the same time with the two modalities, or do you separate them?
We usually like to do them together because the mammogram, particularly for dense breasts, may not show as much as we'd like it to do, and sometimes the ultrasound can assist with that. Also, if the mammogram shows something unusual in a particular area, it can be further evaluated with an ultrasound to see if that something, quote unquote, is either something solid or cystic.
When women get screened and they get their result that says you're fine for now, sometimes they go for 2 or 3 or 4 years and don't get screened again, and then they're fine again. Is that encouraged? Do you think that that's something that encourages women to not do it as regularly as they should when they get a second one that's normal after waiting many years? And would you say that if you've had, the way we do with pap smears, if you've had 3 or 4 consecutive pap smears that are normal, you don't have to do it every year or every 3 years anymore. Is there any such thing when you're doing screening for breasts?
Unfortunately, for breasts, it's not necessarily the case. Breast cancers can grow slowly over time. And actually, when a mammogram picks up a breast cancer, it actually may have been there for a number of years before, just not seen on the imaging because it has to get to a specific size or do something to change the structure in the breast for the mammogram to pick it up.
What size in general? Could you give us a common item that we all know? Is it a pea size? Is it a walnut size? What size can most imaging pick up an abnormal mass in the breast?
Most imaging, it's a bit of a complicated question. Most imaging for a fatty breast, so a woman's breast doesn't have a lot of dense tissue, probably can pick up about 1 centimeter or a little bit smaller, which is probably the size of a pea or a little bit around the size of a pea to the middle of a grape. If you have dense breasts, however, sometimes it may not pick up a mass that's bigger than that because the density of the breast happens to match the density of the cancer. But you can pick up other things like calcium deposits. It looks like you sprinkled salt on a mammogram. And cancers don't just present as one way on a mammogram. Some women get calcifications, which can be associated with cancer. Some women can get a mass or change in the actual architecture of the breast tissue on the mammogram. There are many different ways that cancer can present on a mammogram. So to your original question, the reason we wouldn't want to do a mammogram every 2 or 3 years is a cancer can potentially grow during that time and be picked up by a mammogram annually.
At the top of the time we started talking about it being your first anniversary of your center. Can you tell us something about the center?
I'm very, very proud of it. It's the first year anniversary of the Maimonides Breast Center at the Gilbert Rivera Pavilion at the Maimonides Cancer Center. And it's a center that actually was opened about 1 year ago with the purpose of providing excellent care to patients in Brooklyn for breast care. And this center is particularly wonderful, not only because of the design of the center, the infrastructure is beautiful. It looks like you walk into a spa, actually. It's actually because of the team that's at the center. Everyone has come from some of the top institutions in the country, providing excellent care in their field. The Imaging Center is a breast center imaging of excellence. The center itself, within that short 1-year period, has been accredited by the American College of Surgeons as providing all the standards that the college feels are top in terms of providing excellent breast care. So we're fortunate.
So it's a center of excellence, not only for screening and so forth, but for surgery, for breast surgery.
For breast surgery, for treatments, including medical radiation oncology, for all the care that you need for a breast cancer patient, and for general breast health as well. We don't just treat breast cancers, we also take care of women with benign disease as well.
Now, one of the things that we need to mention is anything that's new with treatment. Women are very fearful about getting breast cancer or getting the diagnosis. What's new in the treatment of breast cancer?
I think there are many things, fortunately, that are new in the treatment of breast cancer. I think one of the most important things is that early detection still matters. So we start with the screening and the pick up early front. We've developed technology that picks up disease a lot earlier. So we've gone from analog or film mammograms, kind of like a film camera, to digital mammogram, kind of like your digital cameras, that picks up disease a lot more quickly and easily than a film mammogram can. We've also developed other technologies like using ultrasound and MRI. At our center, we actually have a high magnet, a 3T MRI, which also has a lot more sensitivity than the traditional 1.5, which is used at other facilities. And then instead of just the imaging, we've also picked up better ways of detecting the cancer through biopsies. We do a lot of needle biopsies instead of surgical biopsies. It's a
guided.
Needle guided by the imaging. That's a very important thing to mention because in the past, everyone would just go into an operating room, take out the area. Now we actually can take a small sample and understand what we're taking out when we actually go in the operating room, saving a woman from an extra surgery.
I hear that you have a special event coming up. Could you tell us a little bit about it?
We have a number of special events, but the most special event we have is on October 6th. It's the Ride to Live. The Brooklyn Bikers, along with the rest of our staff, is going to start at the Maimonides Breast Center and ride from the 64th Street to Sheepshead Bay to increase awareness and spread the word about breast cancer being treatable.
We only have a minute or so left, but if you would leave one message with our audience today, and it's not just women because breast cancer is a family affair, what would that one message be to the women that are listening today?
I think the message is early detection leads to treatment and curing of breast cancer, and that early detection starts with screening. And for the women and for their families, increasing awareness is where it needs to happen. Because the more knowledge you know, the more you can actually benefit, because you'll have more information about getting a cure.
And if you need more information, you can go to the Maimonides Breast Center.
Absolutely, we'd be happy to have you.
So early detection is still your best protection?
Early detection is definitely the best protection.
Thank you so much for being here.
It was my pleasure.
From the big C to COPD. That's chronic obstructive pulmonary disease, an umbrella term for a group of diseases that affect airflow to the lungs. According to the Centers for Disease Control, in 2010, the two leading diseases involved, emphysema and chronic bronchitis, affected more than 13 million Americans. There's no cure for COPD, but there is treatment. Healthbeat Sherry Carabin went to a rehab facility in Park Slope to see it in action.
Are you ready? Okay, let's press quick start.
Started smoking in my early teens and gradually increased until I was up to 2.5 packs a day.
Park Slope resident Thomas talks about the cigarette habit that likely led to his being diagnosed with chronic obstructive pulmonary disease, or COPD.
Try and take nice big steps. Strike your heel with every step.
COPD is one of the most common lung diseases, causing problems ranging from shortness of breath and fatigue to coughing and respiratory infections. There are two main forms, chronic bronchitis and emphysema.
It's really an umbrella term, and also asthma is sometimes considered COPD. It's anything where you have obstruction to breathing out the air that's in your lungs.
Dr. Jeremy Weingarten works in the Pulmonary and Critical Care Medicine Division at New York Methodist Hospital in Brooklyn.
It usually occurs in older individuals. It's usually a disease of smoking, so as you smoke, you get accumulated damage to the airways in the lungs, and that results in what we find clinically, the chronic bronchitis or emphysema.
Let me know if you need to stop.
Thomas was diagnosed with emphysema in 2003.
Probably about a year or so before it got to the point where I was unable to really walk much or do any strenuous activity.
How do you feel on the scale from 0 to 10? How short of breath are you?
If I say now 2.
Now 2?
Mm-hmm.
Okay. It's 3 minutes. Do you think you can do another minute?
Yeah.
Okay. We'll stop at 4 minutes, okay?
There's absolutely no cure. You can decrease the rate of decline in lung function by stopping smoking, and there are certain things that can improve mortality, so survival. Oxygen therapy is one of the only things that will improve survival, but other things that we can do for people, including the inhaler medications, can make people more functional and be able to do more things during the day.
Thomas does use inhalers, but he's also on oxygen therapy 24 hours a day. Does the oxygen make you feel better?
Yes, it allows me to be a lot more mobile.
Let me also check your oxygen while you're doing this. Okay, so stick your finger out.
This past summer, Thomas began participating in the hospital's pulmonary rehabilitation program, which is run out of Metro SportsMed's facility at 263 7th Avenue. If there's no cure, then what is the point to rehabilitative therapy?
The goal of rehabilitation is not to necessarily improve lung function. In fact, it can improve lung function, but to improve everything else about the individual. So muscle strength, the way the heart works, with the goal to decrease the sensation of shortness of breath and to improve functional capacity. So being able to walk more blocks on the street is very important for somebody with COPD.
How are you feeling? Okay? Okay. All right, let's take this off. What I mainly do is aerobic fitness training, which includes walking on the treadmill, for example, or using a stationary bike, an arm ergometer. These aerobic exercises improve the body's ability to use oxygen better by reducing the heart rate and blood pressure. I also use muscle strengthening or resistance exercises, which help improve the strength of both your upper and lower extremity muscles, as well as your muscles of breathing, namely the diaphragm and your intercostal muscles. Breathe out. Very good. I also include stretching or flexibility training, which helps improve the patient's posture, as well as chest expansion and increase breathing coordination.
I've seen a lot of progress with Thomas. We started very slow with just stretching and some strengthening and breathing exercises. Now we're going to very high activity, like doing aerobic activities like lower extremity bike, upper extremity bike. We are hitting more than 10 minutes now. He used to do his flight of stairs just once in a day, and he was scared to do that. He's gone up by 4 to 5 times a day now. So that's quite an achievement, I would say.
Don't do more than 10. 3 sets of 10.
Although it may be too late for Thomas to prevent COPD, he does have some advice for others.
Don't start. I mean, I was one of these smokers that it was my right to smoke anywhere, anytime. Now it's don't even smoke near me.
I'll see you in the next visit. Okay?
This is Sherry Carabin reporting for Healthbeat Brooklyn.
Bye.
Right now, we're going to pick up the pace here and join a group of women in Prospect Heights. As members of Club Workout, they're getting in shape with the help of a live DJ, a bit of self-defense training, and an instructor who takes her exercise very seriously.
Club workout is that combination of having a good time at the club but getting your workout in. We have a live DJ who gets the crowd pumping and gets everybody alive, and I myself work the girls out to it. And the whole feel is you come in, you're at a club, you get your dance on, you get your sweat on, but at the same time, you get your workout in. So even though it's so challenging to do the workout, afterward everybody's just so happy, elated, you know, it's a fun time, it's a good time. So it's that fun workout you can't wait to get to. House music and clubbing out and dancing out is a major part of my life. And I know a lot of DJs, because I dance. And I said, I'm in the fitness field. I run Underground Physique, and basically that's a fitness and self-defense organization. And I thought to myself, well, sometimes too, how nice would it be to teach them the self-defense, teach them the exercise, let them get that benefit of all of it together, mixed in a club atmosphere. And I decided, let me start doing classes to a DJ.
Here we go. 1, 2, 3, 4. How many? How many? 7, 8.
I feel like each class I definitely get out at least 1,000, 1,200 because myself. Some that have started may have 450, 500, 550. I now look at them, I know by the time they leave, because we leave drenched, by the time they leave at least 700, 800, at least. They will get toned. It can help them with longevity, adding years to your life. You must exercise to do that. It can help them be more aware about what to eat and what to put in their bodies after workout, because that's the most important thing, which is why I like to have the fruit and the antioxidants set up so that individuals can, right after the workout, feed the muscles with something that's, beneficial for them.
I've been coming to the class probably over a year now. My health definitely has improved tremendously. I'm more conscious on what I eat, and definitely as far as the self-defense, I don't have a fear of coming home from the train. I used to take the cab home, but now I just take the bus and I don't have a problem now.
5, 2, 6, push.
Whether it's 2 of us, whether it's 4 of us, 5 of us, 8 of us, 10 of us, 12 of us, 15 of us, regardless, we get a full workout and we support each other like, forget it, effortlessly. Everyone's, go, 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 push, push, push if anyone's not into it. Everybody pulls out their best, and just when they think they can't anymore, I make sure we try to tap into their chi and pull out a little extra. They can work out with a group of people, which is nice, and also get the support. Support is also very good to have with working out. I contact my girls each class out of my 3 classes a week. I always contact them.
Just her keeping in contact with us, motivating us is what keeps me wanting to come back. So I crossed the bridge from the Bronx just to be here for this.
I want people to leave here feeling like I did it. I just helped myself. I just treated myself to feeling good. I just did something that gave me energy and gave me stamina and toned me up, and it's helping me lose weight and it's making me conscious and aware of what I'm doing. I feel exhilarated. I love the music. I love the place. I love the atmosphere. I feel groovy. That's what I want. That's what I feel. That's what I get. I leave here like hyped, and that's what I want.
That's all for this month. If you want to watch past episodes of the show, go to brickartsmedia.org/BIT and then click on Healthbeat Brooklyn. And you can follow us on Facebook or Twitter on BK Independent TV. Right now, information about the programs and hospitals we've just featured is about to appear on your TV screen. Thanks for watching, and stay healthy.
Watch this and other Brooklyn Independent Television episodes online at brickartsmedia.org/BIT.